Which parameter is increased in hepatectomy? Why there is a gynecomastia in hepatic failure, doctor? Because normally estrogen is metabolized, it could not be. That's the reason there's a development of the gynecomastia, hence it elevates is what need to be basically remembered. This is a very challenging and interesting question. Do you think it is the same question which came in the exam? Those who have written the test can be able to say. Is it the same framing? Good. Because there was a small confusion. Is it increasing appetite or decreasing appetite? Decreased appetite only. Okay. Now we can see the end of this story. Please remember, there are certain hormones which are released by the hypothalamus. Out of that, this corticotropin releasing hormone is very much there. It is the one which will cause the decrease of the appetite. That is a very well proven fact. There is no confusion about it. Only thing is, now we have to talk about these two newly appearing terms, that is orexin and ghrelin. These are the two important things. I'll take 2 minutes of your time for you to make you the masters. Before that, this neuropeptide Y, it is basically a 36 amino acid peptide which is produced by the sympathetic nervous system, gut and the brain, and it has got a very key role in the cardiovascular and the hypothalamic function is what need to be basically remembered. It will cause the blood pressure to become elevated. That's the reason whenever there is any stress, if there is any septic shock, if there is any relaxation of the colon, in all these situations, neuropeptide Y is having a very crucial role, is what need to be basically remembered. If you give amphetamines, typically neuropeptide levels is found to be inhibited, and in the Alzheimer's, very important, neuropeptide Y becomes decreased, is considered to be one of the parts. Neuropeptide Y will also inhibit the norepinephrine, and it acts upon the alpha-2 adrenergic receptors is what need to be basically remembered. Now what is this ghrelin? Typically it is a shortcut and acronym for growth hormone releasing peptide. First of all, it is not produced by hypothalamus itself. That's the reason it can't be answered at any cost, because what is produced on the hypothalamus is what had been asked. Typically it is produced by the cells which are lining the stomach. It stimulates the appetite. And typically before a meal, we are so hungry because ghrelin levels are increased, and after the meal it becomes decreased. Now all of you know there is something called leptin. So basically it is the counterpart for the leptin which is produced by the adipose tissue, and ghrelin also stimulates the growth hormone from the anterior pituitary. What happens after we eat? We need to grow. So that's the reason it becomes produced, and after that it will make us grow by stimulating growth hormone is what you can remember. Now there are certain receptors where this ghrelin will go and act on the hypothalamus to make our satiety to increase. So in the arcuate nucleus and the ventromedial part of the hypothalamus, which are the classical epicenters for us to eat and to not eat, it is this ghrelin which has got receptors is what need to be basically remembered. Now in what situations in pathology, clinical medicine do we require this? Typically in the obese individuals, if you compare with the leaner individuals, the ghrelin levels are lower is what need to be remembered. Now you may ask a question. Sir, ghrelin stimulates appetite, you are saying, and obese people it is low. Without ghrelin only they are eating. That is the reason they are obese is what you can remember. There is another reason for that. So whatever, don't apply two philosophies for the same concept. Sometimes it can make you lead towards wrong. So ghrelin definitely increases appetite, but the levels are lower in the case of the obese individuals is what I want to underscore to all of you. Similarly, in the cancer-induced cachexia, there are very high levels of the ghrelin. Similarly, in the gastric bypass surgery, there is a dramatic lowering of the ghrelin levels. These are all the things which need to be basically remembered. In this context, tomorrow's exam you are going to get a question on obestatin. What is this basically? In the late 2005, last year only, at least 2008 AP entrance you can expect this to come in your paper. It decreases the appetite. Both the obestatin and the ghrelin, they both are encoded by the same gene is what I want to underscore. Then one more important options given to you was orexin. Basically what is this? This is otherwise called hypocretin. Japanese are associated with a lot of research on the neurohormones associated with the eating, doctor. So that's the reason Masashi Enegasawa is the one who is associated in discovering this orexin. Basically, this orexin, otherwise another scientist called it as hypocretin, both have got a similar action is what need to be basically remembered, and both these peptides are the ones which are produced by the hypothalamus. So there's a reason now we have two possible answers there, which are produced by the hypothalamus. One is hypocretin, other is corticotropin releasing hormone. But which is the correct answer? Let us look at. Orexin typically will be involved in the stimulation of the intake of the food. It won't decrease the appetite, it will increase the appetite, is what I want to underscore to all of you. One more important role of the orexin, the neurotransmitter, is in the narcolepsy. So narcolepsy is that excessive daytime sleepiness. It is inability to consolidate the wakefulness in the day, and it can have the cataplexy, where there is a sudden loss of all the muscle tone. So people having a lack of this orexin are known to be predisposed to the development of the narcolepsy. So that's the reason you need to remember in relation to that. So wakefulness and our appetizing, both the things are basically because of the orexin, is what I want to underscore to all of you. So there's a reason, doctor. Finally, in conclusion, we can say the orexin increases appetite produced by the hypothalamus. Ghrelin produced by the stomach, and it is also associated with the appetite. And you are having corticotropin releasing hormone, it is the one which is produced by the pituitary, and it decreases the appetite. So finally, the corticotropin releasing hormone becomes the answer. Let's go to the next question. Kluver-Bucy syndrome is because of the lesion in which important structure? So we discussed about Broca's, we discussed about so many things. I think we missed Kluver-Bucy, no problem. This entrance will give us an insight into what are the possible this thing. We'll go a little more deeper in the future discussions. So amygdala is the one which is associated, and inferior temporal cortex, if there is any bilateral destruction, this Kluver-Bucy syndrome will occur. Now, certain meningoencephalitis, patients with a Pick's disease, and those who have a surgical lesions of their amygdala, in all these people Kluver-Bucy can occur. Now what are the classical symptoms of this Kluver-Bucy? What happens if amygdala is destroyed? Typically, hyperphagia is one of the important features because in the Kluver-Bucy. One more important thing is, if amygdala is destroyed, if monkeys which were exposed to fear situations, which are afraid to enter into that, typically they will display no anger or fear. When they are exposed to the fear-inducing stimuli, that is what happens with the amygdala. So amygdala is also associated with the fear. So probably one day if we suffer Kluver-Bucy after the result comes, it's no problem, because we can be free of all the fear, right? So inappropriate sexual behavior also is another important presentation. They also suffer from visual agnosia, that is they will be having inability to visually recognize the objects though the visual system is functioning. So that is another important problem. And why they will suffer from visual agnosia when the amygdala got destroyed? Typically what happens in them is, the object identification, generally we require our visual cues. They start using the other ways by touch and other ways, or keeping in mouth, they will try to recognize the object. They don't require the vision to recognize the object. So virtually they start complaining of not seeing anything. They will be ignoring totally that there is a visual system existent in their body. So that is the reason they will be suffering from visual agnosia, is what I want to underscore to all of you. So what they found is, all that hypersexuality which you see in the Kluver-Bucy syndrome typically is not because of that. The only thing is they are not able to discriminate between what belongs to their species. So that is the reason, doctor, one of the eminent man who did work on the Kluver-Bucy has said, Kluver-Bucy patients don't know what the prey is, what the mate is, what the food is, and what is it meant for. So probably a Kluver-Bucy goes for a honeymoon, he will virtually eat his spouse and come back, because he can't recognize what it is meant for. So that's the reason you have to be very sure about. So amygdala is the final answer. So don't worry if you have answered some of the questions wrong, relax yourself and basically enjoy the knowledge. That's more important, doctor. So in sensory cortex, typically the lesions will cause which sensory modality to become most affected? Fundamentally, the sensations are divided into the discriminatory senses and non-discriminatory. What are discriminatory, doctor? Proprioception, vibration, fine touch, these are all called as the discriminatory. If you look at all these discriminatory modalities, that is the proprioception, the stereognosis, they are immediately processed by the central nervous system, that is medulla, cerebellum and thalamus. There is no hierarchy existent there. Straight away they reach and there they will be processed and it happens. Whereas if you take the pain, there is a lot of gating which is required in our spinal cord. There is something called internuncial neurons which will gate, otherwise we will suffer all the pain in the world. Some amount of it, spinal cord will say not required to be transmitted to the brain and told to the brain it will decide. That's the reason, doctor, there are a lot of interconnections for the transmission of the pain. That's the reason unless there is a very extensive lesion at multiple levels, then only the pain perception becomes damaged. Whereas the proprioception in most of the sensory cortical lesions, it is the proprioception stereognosis, these sensations are the first to become affected is what I want to underscore to all of you, because they have less amount of collaterals or internuncial connections. That's the reason they are the ones which become first affected is what I want to underscore. So finally, what is your answer, doctor? In the sensory cortical lesions, it is a proprioception which is most affected. Let's go to the next question. All of you know fetal RBCs have got a very short half-life of about 80 days. Now this is another interesting question. Which is the reflex that is not neurally mediated? There is no neural pathway. So it is the gastrin which is important for, which reflex, doctor? Gastrocolic reflex. It is the one which is predominantly gastrin mediated, not neurally mediated is what need to be basically remembered. Now this is another important question. If there is vasopressin, there is a decrease in cardiac output. So what is the area in the brain where it will go and affect it and will cause the cardiac output to become diminished is a very important question that you need to identify. Basically we have V1A, V1B, V2. They are the three important receptors for the vasopressin. V1A, there is a vasoconstriction, gluconeogenesis in the liver, platelet aggregation, release of the factor VIII, von Willebrand factor, release. That's the reason in some of the patients who suffer from the von Willebrand's disease, one of the practices is to administer the vasopressin so that it will go and release the von Willebrand factor by acting on the V1A receptors is what need to be remembered. V1B is associated with the corticotropin secretion, and the V2 is the one where you find in the cortical collecting ducts. It is that antidiuretic hormone action of the vasopressin is there, no? There you find the V2 receptors. Now, the vasopressin which is released within the brain is implicated in a lot of functions. Memory function, circadian rhythm, and the aggression, blood pressure regulation, temperature regulation, everywhere vasopressin is very much implicated. Now which area in the brain is it acting on? Area pars prima is a very important area on which typically the ABBP will be acting, and it will be causing the sympathoinhibition. Generally our baroreflexes will cause sympathetic stimulation to occur, and this will go and inhibit it and decreases the cardiac output. So that's the reason it is the area pars prima where it will be acting. What is this area pars prima is my question to all of you. Basically there is one important area called median eminence, all of you know very well. It is one of the important area in the hypothalamus. It is the point where all the hypothalamic hormones will be coming to one place. It is like a chaurasta. From there once more it becomes released towards the pituitary.